Hello, everyone. MDA 5 related interstitial lung disease poses significant challenges in diagnosis as well as management. It's a scenario where an MDD team is required, pulmonologist, radiologist, rheumatologist, and experts in this particular field. In today's webinar, the international expert is Dr. Steve Nathan. He is from University of Virginia in US, where he runs an advanced lung diseases as well as lung transplant center. He's an authority on interstitial lung diseases. Along with him, we will have rheumatologist Dr. Smriti Ramtake from Nagpur, as well as Dr. Khushbu Pilania, who's a radiologist from Noida. The entire episode is going to be based on a case, a real life case, and the difficulties and the problems which we faced in its not only the diagnosis as well as the management and the management of complications. Throughout, we are going to be guided by our expert, Professor Stephen Nathan, as well as the other MDD team, which is going to be taking part actively to drive the case as well as its discussion. And I'm going to be also there with you. Watch this episode and let us know your thoughts about it, that what are other things which are still not covered here. So let's begin. Dr. Rahul Kheda will present the case and then we will take the case forward.
So we are presenting a case of 62-year-old female, teacher, never smoker, who presented to us with chief complaints of fever, shortness of breath, and cough with expectoration for 2 weeks, and history of 10 kgs weight loss in last 6 months. She also had joint pains, multiple small joints were involved for last 6 months, treated at seronegative RA on treatment since March 24 on HCQ 200 OD and TAP methotrexate 20 mg once a week. She is also diabetic and there are no other autoimmune symptoms. Her room air saturation was 96% and there was no significant finding in general or seismic examination. This is a picture of her hand which shows swan neck deformity. So our main concern was her unintentional weight loss of 10 kgs in last 6 months. These are her lab investigations. A sputum culture was positive for Klebsiella. Gene expert was negative. So for evaluation of a weight loss, we did a PET CT scan. This is a PET CT scan which was negative for any PET avid lesions.
So, Khushbu, would you like to make any comment on the CT PET scans? Although we don't have the lung images on the normal CT here, but we have PET images only.
So, as Rahul said, there aren't any PET avid lesions, and we are looking at a ILD, so we can definitely appreciate those pleural irregularity, and I'm suspecting some interstitial abnormality. So, we're just seeing some pleural abnormality on the mediastinal windows, and obviously there is some lung pathology which we will want to have a look on the HRCT images better.
So FO bronchoscopy was advised to the patient, which was denied. She was treated with antibiotics as per the sensitivity report. Patient was afebrile then. So we did a repeat CT scan of the patient after 14 days of antibiotics. This is a repeat CT scan.
I think the first question will go to Khushbu, that looking at the CT scan, what would you think about? What would be your advice to the clinician? initially because we did only PET scan, so we thought, okay, if it's the infection part, there is no malignancy, let's treat her for the infection. She refused for bronchoscopy. So we did an internal, maybe just too early for 2 weeks, but we did the CT scan at 2 weeks to get a good quality look at the lungs. So what's the kind of interpretation you will give on this, and what would you like for us to follow up on this patient?
So when we look at the CT scan, there is definitely a diffuse lung disease, and it appears to be a diffuse interstitial lung disease with some fibrosis towards the periphery. There are some areas of patchy ground glass attenuation, especially in the upper lobes, with a background smooth diffuse ground glass attenuation also in the upper lobes. And there are towards the periphery, alongside the fibrosis that is going on, we are seeing some wedge-shaped areas which look more like consolidations, peripheral wedge-shaped consolidations. So there can be an element of superimposed infection by the patchy ground glass that we are seeing in the upper zones, but nevertheless, there is a background interstitial lung disease, a pattern that fits into an alternate diagnosis. It's not a UIP, neither a probable UIP pattern. It's a pattern which fits an alternate diagnosis, has some organizing pneumonia component alongside some NSIP pattern that it looks to me like some background NSIP with superimposed organizing pneumonia. So that's what my impression.
Steve, what would you say about it?
I agree with the interpretation. What I was trying to also look at or try and evaluate is I think that there's evidence of traction bronchiectasis as well at the bases, which kind of infers that maybe there's a more chronic fibrotic component to this. It's interesting because we agree on all the changes that we see. But, which box do you put this in terms of UIP all the way to alternate diagnosis? And I don't necessarily disagree that this is alternate diagnosis suggested because it seems like there's something else going on here when you think about this case clinically. But if you think about, evidence of subpleural reticulation, if there's evidence of traction bronchiectasis, there might be some folks who look at that and say, well, gosh, this is more like a probable UIP pattern. Although I agree with you, when you put it all together, I think that we probably looking at an alternate diagnosis. But yeah, the nature of the fibrosis is such that it's not that typical subpleural reticulation, even though it is out in the periphery. But I do worry that there's something else going on here. I guess one of the questions is, it seems like there was an infection, Klebsiella, it was treated. It would be interesting to know what the CT looked like initially, to know how much of that ground glass stuff is just residual and resolving from that infectious episode. So I know this is a CTD session, so there's a bias here, and I'm sure we're headed towards a CTD. But it could be that this is just an infection. Certainly showed the hand changes, which are consistent with rheumatoid arthritis. But could there be something more than just rheumatoid arthritis? I missed what the patient was getting in terms of treatment, if anything, for the rheumatoid. I might have forgotten, but certainly if she was getting treated, she could be immunosuppressed and predisposed to just a regular Klebsiella infection.
So, Steve, she was on methotrexate.
Oh, she was. Sorry, I forgot that. You go 2 slides and I forget what was on the previous slide. So not the most potent immunosuppressive drug, but certainly something that could predispose it to infection.
So that's it. So when we get this kind of a CT scan, I think I'll go to Smriti. That he was diagnosed. She was diagnosed as a seronegative rheumatoid arthritis, and this kind of a picture with the peripheral fibrosis, with little bit of honeycombing kind of thing which is coming up, and obviously we are looking at kind of thing which will be rather consistent for RA-ILD. Are you happy with this kind of a situation right now in this patient? That patient had RA-ILD and super added developed infection because of immunosuppression, which Steve also said, and we also thought about it.
Yeah, it's very probable that the patient had a underlying autoimmune condition, I don't know exactly whether it's rheumatoid or it's some other connective tissue disease which has been missed, or which might show its like the patient comes to us with arthritis, but the patient also has sometimes subtle Raynaud's, or a history of oral ulcers, or a history of hair loss, or dry eyes, dry mouth, which we even as clinicians miss at times when we see the patient for the first time, and over years the patient may evolve into something which initially looked like rheumatoid, which might go into something more than that. And I think the other thing, which was that the secondary infection, yes, methotrexate predisposes the patients to secondary infection, and we have patients on methotrexate who have not been vaccinated getting recurrent infections more than the normal people. They have frequent infections. So I think the other thing was the patient has huge degree of inflammation because there's a lot of weight loss, over 10 kg weight loss. So it would be worthwhile looking at the inflammatory markers, how they are.
So I think
Yeah.
so we had CRP, I think Rahul, that was nearly normal only. But I think you have brought in a very good question, and I think I will go back to both Steve as well as Smriti. That there is a lot of thinking in the still in the pulmonologist field that methotrexate cause this kind of a lung injury, and is it that
Sorry, I just
Smriti, you can say
Sorry,
first.
Deepak, you're breaking up a little
no.
bit for me
Yeah,
there.
yeah. The same,
So
yeah.
methotrexate induced lung injury.
Yeah, no, this doesn't look like methotrexate lung injury. In fact, we do not recommend stopping methotrexate if the disease is well controlled, and continuing with the lower dose of methotrexate and adding on probably something more for the ILD rather than stopping methotrexate. Because what the problem we usually face is once the patient's methotrexate is stopped, it's very difficult to control the joint symptoms because the other drugs like mycophenolate and azathioprine, cyclophosphamide, they are not able to control the joints. They may take care of the other parts of the disease, the lung, but they are not able to take care of the joint. So stopping methotrexate is not a very good option for this patient. I think we should not make
Right.
villain out of methotrexate.
So practically, you are trying to tell us this is not like a methotrexate-induced lung injury, and you should not consider that, you need to check back on your methotrexate. Steve, your comment on this?
Um, Yeah, I would agree. I think that if you just look at the rheumatoid arthritis population, many of them have occult ILD, 20% or somewhere thereabouts, depending on which paper you read. So it might be that this was uncovered just because this patient had this infectious episode. It would be interesting to know what the PFTs are, and certainly something to be followed more closely. If this is truly rheumatoid arthritis, then that's the CTD ILD that most closely approximates IPF. So when we think about therapies and and the fibrosis here, I think something looming in the background when the dust settles is, will this patient benefit from additional antifibrotic therapy? And so, if you look at nintedanib approved for progressive pulmonary fibrosis, we don't know necessarily that this is progressive at this point, but certainly this patient should be followed closely with serial PFT, see how they're doing, if they have any residual symptoms in terms of shortness of breath. And then I think that becomes a consideration down the road. When we treat the ILD component of a CTD, we think about the two components. Is there ongoing inflammation, which is predisposing to the fibrosis? And typically, if we think that there's an inflammatory component that's perpetuating the fibrosis, then our go-to is more mycophenolate. And certainly we've have a bunch of patients on methotrexate together with mycophenolate. But I think this is where a multidisciplinary approach in conjunction with our rheumatologist becomes very important in terms of trying to figure out the best regimen that's going to control the joints or any other extrapulmonary manifestations, and what's going to help control what's going on in the lungs.
So I think very nice comments from Steve, and I think all the viewers, please notice two things very clearly. This is not the typical type of a methotrexate-induced injury. And secondly, very importantly, that in rheumatoid arthritis patients, you can have a 20% of patients accidentally picked up on a CT scan that they have ILD. They have ILD because ILD is associated so commonly with them, but they may have no symptoms. And in this patient, primarily because of the infection, we have been able to pick up everything. So perhaps that was one of the thought process which was going on in our mind also. And I think take home message would be very clear that don't be talking about methotrexate. If there is a patient on methotrexate, everything is not because of methotrexate. That was the thought process which went on for last 10 years almost, and we have been struggling, and rheumatologists have been teaching us that it's not methotrexate, you are unnecessarily withdrawing the drug. And Smruti made a very good point that if you withdraw the drug, joint symptoms will be very difficult to treat with slowly acting drugs, which you are going to replace with the methotrexate. So please don't do that, because you are going to destabilize the patient completely. Steve said that let us look at the lung functions and other things of the patient. So Rahul, how are the lung functions of this patient?
Yes.
Can you tell us how are the lungs looking at this patient?
So
Yeah.
patient had a restrictive lung function with the FVC of 74% and TLC of 79% and diffusion capacity of 53%.
So we had restrictive defect, we had diffusion impairment, so everything was there on board in this patient. And echo you said is normal. So, okay, so let's see next what is it there that we were when we saw this patient, we had couple of things in our mind, like we this patient is already under rheumatology follow-up. Let's take a rheumatology opinion. And since the patient is just recovering from infections, why unnecessarily to do more tests at the moment? Let's wait for some more time to do the test done. But obviously there was a lot of concern about early to do something about this patient, because she had such a big trouble time. And weight loss, which was the primary concern of the patient, was now stabilized, but that was only for about 2 weeks to 4 weeks, so it doesn't make much of a difference. So what happened next to this patient, Rahul? These were the questions in our mind. We did send the patient to rheumatology also. Next slide, I think, Rahul. Yeah, so we did a rheumatology profile. Okay.
So
That is interesting. This patient is 1 in 100 ANA, and this
MDA
is diffuse finely speckled, and then of course we have MDA5 coming out to be positive. Smruti, I'll go straight to you. How will you interpret this?
So probably it was the weight loss. The rheumatoid won't explain 10 kgs of weight loss unless and until the patient has some underlying big infection or the CRP is very high and other markers, inflammatory markers are very high. But this explains, the profuse inflammation. MDA5, the patient already had it and the patient presented with joints. So patients always put this bouncers in front of us when they come only with Raynaud's or they come only with the oral ulcers, and then they end up showing the real thing. So I think
Audience, that this case has not been seen by Smruti, so you can imagine that how much she can see what is going to come. So this shows how much is a rheumatologist important in the MDT. Khushbu, you had any intentions to tell us that this patient might come out to be myositis on the CT scan? You would have given some clue to the clinician that look for that it is not like Steve said very classically, it looks like IPF. If you have rheumatoid arthritis, obviously perfectly fine, it fits into rheumatoid arthritis like pattern which you get on a CT scan, which is like a probable UIP, or maybe somebody might debate into to a UIP even. So what is your comment on that, Khushbu?
I have a differing opinion because I thought that it should be an alternate diagnosis. And it did look like I was quite sure of the OP pattern. I was suspecting a background NSIP as well. So we know this that the NSIP OP overlap though occurs with rheumatoid arthritis also, but it is more common with the myositis related ILDs. So though I wouldn't have been bold enough to put it forth there and then on my report, but yes, that did strike around.
Okay, I'll go to Smriti again. Smriti, this ANA, how important is ANA when we talk about myositis related, diseases?
it's an important investigation because we see the ANA profile. And many patients of mixed connective tissue disease have a component of myositis. The undifferentiated connective tissue diseases, they have myositis. Then we have the patients who come predominantly only with myositis, like dermatomyositis and polymyositis. So then, and the IIMs now with MDA 5. So ANA is a very important test because it makes us look back at the patient whether we have missed out on something. Because I'm pretty sure that we in our busy OPDs are seeing patients and primarily labeling them as rheumatoid, seeing looking at the joints, and sometimes we might be missing them. I'm very sure about it. But then when they come with such odd histories like such profuse weight loss, hair loss, oral ulcers, patient has Raynaud's or tight skin, patient has some component of myositis, this makes us alert to the possibility of underlying connective tissue disease. And especially when the patient has interstitial lung coming up, yeah, we need to look at them more closely.
So, Steve, like as a pulmonologist, when we were encountered with this report, there were a lot of murmur going on that MDA5 can come out to be non-specific positive. There's nothing like myositis, muscle enzymes are normal, everything is normal in this patient. So maybe it is just like that. 1 in 100 ANA positive is also not a big thing. So like there was a lot of in pulmonology field in our specialty we had a talk about it, and at that point of time I would admit that we didn't have a rheumatologist on board at that point. So how do you take this kind of situations in your setup, Steve?
It's very interesting. The MDA5 changes the whole discussion and equation. And actually, while you showed this, I had a question for Smriti in terms of, sometimes the general population, if you checked 100 individuals, 2% of them would be positive rheumatoid factor and ANA.
Yeah.
But my sense is always MDA is pretty specific. But my question is, how often can you just have a false positive incidental MDA5? I mean, we can fit this into this case, but it does change the discussion quite significantly. So let me ask you that question first before I talk further about MDA5.
So let me be honest in answering that we are not doing routinely the MDA5 or the myositis profile in patients. And there is, at present in India, we don't have any data which shows us what is the actual prevalence or incidence of having MDA5 antibody. Like ANA and rheumatoid factor, we know that normal people can have a positive ANA and a positive rheumatoid factor. But about MDA5, I think we need to see. Actually, no one has seen it, at least in the Indian population.
Yeah. And I'm not aware of any literature in the general population of MDA5 being, 1% of the normal population. So we would take this pretty seriously, and
Yes.
the patient would switch categories to, having a myositis. And we do see, I would say in our institution, more and more MDA5 positive patients. We probably get maybe I want to say 5 to 10 a year. I think the more you look for it, the more you find it. And as I said, this does change the equation because of all the myositis patients, these patients tend to have the worst prognosis. And so we tend to be very aggressive about therapy. If they are of transplant age, we will institute a transplant workup at the same time because we know that many of them might not respond. They are the group that is more predisposed to acute exacerbations. And so going back, even though we had the Klebsiella, I could hypothesize that maybe this was an acute flare of the MDA5 with acute lung injury from that, but the patient responded to steroids, so that becomes, to antibiotics, so that becomes less likely. I would be curious if the patient did get some steroids at the same time for whatever reason. But it's less, if they're having an acute exacerbation of MDA5, it tends to be quite unresponsive. So the question is how aggressive Deepak, to your point, a lot of these patients, in fact, most of them will have normal muscle enzymes and have no muscle symptoms. So I wouldn't let that put me off from the diagnosis. And then the question becomes, how aggressive to get with therapy. The patient already has had this Klebsiella pneumonia, but if these patients remain acutely ill, a lot of times we'll plasmapheresis, we will use a B-cell agent like rituximab. But I think it depends on how much recovery the patient has from this apparent pneumonia.
So I think, Steve, you brought this point very well that this patient did receive antibiotics only, no steroids, and the patient did improve with that. And specifically, we didn't want to give steroids because we didn't want to mess up the whole thing at this point of time. And we were trying to find out that what was the reason of weight loss, because patient got admitted primarily for the weight loss, not for
Yeah.
anything else. Actually, and she thought she's got a malignancy because there is a family history of malignancy there. And when MDA 5 came positive, which we know that we were like more concerned about it. And
Yeah.
that is why I'm very frankly telling you, we referred it to rheumatologist because we thought we need a rheumatologist on board for this. And as you said very rightly, whenever MDA 5 comes up positive, it's a red flag. And I think that's a message. And you can see in the chat box, there are so many questions already poured in. I do not know how we are going to take this. So many questions. People are asking that why were the opacities still there? Is it consistent with seronegative or not? People are even asking us that can it be just a post-infection sequelae where there is like, patient had an infection and some fibrosis and that is going on, like patient had in post-COVID. So people are even considering that as a possibility out here. And in fact, we also thought like that it is an infection. Let the infection settle down. And in the meantime, at least MDA 5 requires a rheumatologist on board. So we did send for a rheumatologist. Okay, Rahul, what happened next? So we asked for a rheumatologist, and what happened, Rahul?
So the patient was reviewed by rheumatologist and was started on MMF 1 gram a day and prednisolone 20 mg a day.
So some amount of importance was given definitely to the disease, as well as the autoimmune profile which had come
Yeah.
out to be positive. And I think they were little more cautious about it because the patient had just recovering from Klebsiella pneumonia. And we know that these patients in India, Steve, it will be very unusual for you to realize this, that in India to get a Klebsiella pneumonia is very easy, to get it resistant is also very easy, and to treat it is also very difficult. It's very difficult because it keeps recurring, and especially in immunosuppressed patients, things become very, very difficult. So, in fact, we had a lot of internal discussion in MDT that is MMF and oral steroid or 20 milligram enough, and we try to look at into ACR recommendations. So, Smriti, I think this is as per the recommendation or not?
Yeah, no, it's as per the recommendation, but they are putting a lot of stress on giving JAK inhibitors as well as the CNIs, which work well. And the thing is that whenever myositis is there, and the underlying myositis is there, I think we should use more than one agent. We should be more aggressive than the what we
So,
would be in a rheumatoid or
just
mixed
so
connective tissue
you're saying
disease.
rather than just mycophenolate, we would have been more happier to have maybe tofacitinib along with it
Maybe on follow up.
on the follow-up
Yes,
of these
on
patients.
follow up.
Any
Yes.
comment on your side before we move on? The guidelines are like using steroid and MMF.
Yeah, but we need to evaluate the say this in this patient. Her weight loss is one of the markers for her inflammation. So we should be guided in this patient by the weight.
I do
That
not
should be our guide. That should
know
be
others that
along with the lung parameters. I am talking about the overall patient. One of the guide whether we are going rightly regarding the therapy. Weight will be our guide in this patient. Whether she is putting on weight, how is she improving? The improvement parameter along with the PFTs and the CT scans would be her weight.
so you need to monitor the patient more closely. Is
Yeah,
that right, Smriti?
exactly.
Okay. So Steve, any comment on this?
Yeah, I agree with what's been said. I'd mentioned rituximab and plasmapheresis, but that's more in the context of patients who are acutely ill, who, are you worried that they headed in the wrong direction towards intubation or otherwise. But I agree with multimodality therapy. And in a patient like this, many of our CTD ILD patients are on mycophenolate and steroids, but I agree that we worry most about these MDA5 myositis patients. So I think for a patient like this, I would settle out on probably triple therapy to start with some prednisone, mycophenolate, and we would add low-dose tacrolimus as well. So the CNR, calcineurin inhibitor, and we would run them probably in the range of around 5 to 10 in terms of a trough level for the tacrolimus. And then
we would monitor very closely. If they got into trouble and required readmission with, an acute exacerbation, then we would resort more to the big guns like rituximab and plasmapheresis. The JAK inhibitors, once we get into that realm, then I'll call my closest, dearest rheumatology colleague to help us out in terms of, okay, when's the time to start a JAK inhibitor? So I think certainly my comfort zone, and I think most pulmonologists' comfort zones are less so with the JAK inhibitors. And once again, this is where a multidisciplinary treatment approach becomes very important.
So
I
JAK
think
inhibitors, I would just add a comment that the patient was already on methotrexate, and if I want to replace methotrexate, and if I am given a choice between JAK inhibitors and CMI, I would go for a JAK inhibitor for her joints.
for the joint involvement.
Yeah,
Okay, correct.
so it works
That's
both ways.
That's a very good clue that when you really are looking forward to the joint, perhaps the JAK inhibitors would be more effective where you would like to use. You said TAC, I think Steve gave an answer that maybe another third drug TAC should have been given. But anyways, let's see what happened to follow up. Yes, Rahul, what happened to this
The
patient?
patient followed up in at 2 months. She reported in the emergency room with breathlessness and swelling around neck, which was spreading to all over her body. Her room air saturation was 80%. She had subcutaneous crepitus over neck and along upper chest. So this is her CT chest.
So we see air everywhere. So Steve, tell me what would be your comment on this?
Well, significant pneumomediastinum tracking up to the into the neck area. The lung remarkably looks like it's up. I was half expecting a pneumothorax, but maybe that's a result of the prior pleural disease and pleural scarring, and that's why it manifested as a pneumomediastinum, because there was kind of an autopleurodesis, maybe from some chronic pleuritis previously. And then if you can go back up, I think the interstitial markings are increased. Looking, I didn't see any ground glass or alveolar infiltrates, but I could be wrong, and that's why I wanted a second look. So it seems like the main thing that brought this patient back was this pneumomediastinum, but I do think that the interstitial markings are increased. A little bit of pleural thickening on the right.
Khushbu, do you think that the disease has also progressed?
Yes, sir.
I
So
think
the
it's
necrosis component and the reticulation markings have definitely progressed.
definitely,
But the patchy ground glass which we were seeing in the upper zones, they have kind of resolved. They've gone down.
yeah. So it's interesting that there has been such progression of the fibrosis. I mean, that's a lot of progression over 2 months. And then obviously there was a bleb or something that blew, wasn't able to manifest as a pneumothorax and tracked up into the mediastinum and into the neck. But yeah, I think this goes back to, I was expecting more of an acute lung injury being the risk in this patient because of the MDA5, rather than this significant progression of the fibrosis.
Right.
I
So
don't know. It's so easy in retrospect. I don't know if the tacrolimus would have prevented this. Personally, I doubt it, but
think
that might have been a
that was a very good
consideration.
question, Steve. You said that, maybe always in retrospective in this question, we thought that maybe we should have gone to triple therapy as Shruti has suggested. But I think MDA5 was not taken that seriously, Shruti. That's the very, very important aspect of it. And there's somebody who's put a question, occupation. Occupation, she was a teacher. Why so early CT? And is it not too early to start MMF? So I think you just see that we are not early, we are in fact late in this disease. That's where when MDA5 comes actually. You cannot be early, you can be late actually. So that's what the thing is. The guidelines are saying that you can use 2 drugs, but Steve and Smriti were not happy with 2 drugs. They wanted to give 3 drugs to this patient upfront. And now looking retrospectively, it does seem that it makes sense actually. This patient should have been more aggressively managed. What happened, Rahul, next?
The patient was put on high flow nasal cannula, which was later
Your
shifted to
slide is not changing, Rahul. Can you change your next slide, please? Yeah. So now she's showing, show the signs. She has a shawl sign. Look at her face. All the facial rash is there. Now things are coming up.
Yeah.
She had typical shawl sign actually. Now all this neck area, you see that there is so much of this thing, and this is after the all this pneumomediastinum and subcutaneous emphysema has subsided. After that, this is all what is we are looking at this right now. Okay, next slide, please, Rahul. Okay, so we know MDA5. Go ahead. What is next now? How did you treat this patient at this point of time?
Patient was managed conservatively, and in 2 weeks, subcutaneous emphysema and pneumomediastinum resolved. She was given pulse methylprednisolone 250 mg in a day for 5 days, and rituximab was given 1 gram, and which was repeated at 2 weeks. So she was discharged on prednisolone 80 mg a day and MMF 720 twice a day, and trimethoprim sulfametazone IV IG option was given to the patient, which was refused.
So now is this adequate, Steve and Smruti? So first, Steve, what would you do? Smruti will tell us later.
I think I see the answer at the bottom there. What about antifibrotics? I would say definitely antifibrotics. There's definitely evidence of progressive fibrosis, worsening symptoms. So whichever way you cut it, this patient qualifies as having progressive pulmonary fibrosis. And so I would definitely look to add probably nintedanib for progressive pulmonary fibrosis. But I want to go back to that initial presentation and the patient. I'm not saying I would have done this, but when you look at the patient's lung function, I think the FVC was in the 60+% range, and there was fibrosis. And so could you have made a case even then to put the patient on an antifibrotic? If you look at our guidelines for what is progressive pulmonary fibrosis, you have to document 2 of 3 different domains: increasing symptoms, worsening CT, or worsening physiology. But even though you didn't have that, that patient at some point had progression, because very few patients start out with an FVC in the 60% range. Personally, I wouldn't have put her on an antifibrotic at that initial presentation. There probably wasn't enough information, and she had that acute infection. But it's interesting to go back and pontificate that, well, gosh, maybe we should have put her on an antifibrotic because it's, the fibrosis really took off. I think at this point, I would definitely put on an antifibrotic though.
Good point taken. So apart from all other treatment, now Smriti, I'll ask for you, I think why we didn't start the antifibrotic, because inside our heart we felt that the immunosuppression was not adequate. We
Yeah.
had not dealt with MDA5 more aggressively as we should have. So maybe that was the reason. So Smriti, anything else you would suggest in the management part at the moment?
I think once MDA5 is positive, we need to call the patient for follow-up more frequently.
No, from the treatment part, methylprednisolone and rituximab.
Yeah, no, yeah. But just the one thing that I wanted to add was that they should be
they
called
should
back more frequently,
More
so that
frequent.
we
Close
don't
follow.
miss out. Yeah. And from the treatment part, I think next in the second visit she was adequately treated. Mycophenolate dose is quite good, but adding an CNI or JAK inhibitor will help this patient.
It should have
Still,
been.
I feel so.
What happened? Right. So I think the message from rheumatology is that we are still under immunosuppressed this patient. So basically, this patient requires more vigorous and perhaps more thorough treatment, or perhaps more intensive treatment in comparison to our routine CTD ILDs. Next, please, Rahul, what happened to this patient? We didn't give antifibrotics, I explained. And of course, these are the guidelines which again tell us that you need to choose again from mycophenolate, obviously after that rituximab and CNI, or for JAK inhibitors, which Smriti has already spoken about. Go to the next slide, Rahul. Yeah. What happened to this patient now?
So at 1 month of follow-up, patient reported again in emergency with breathlessness and reappearance of swelling around the neck. This time her room air saturation was 88 and subcutaneous crepitus was present. This is the present CT scan.
Run the CD. I think the entire picture which Smriti and Steve, I would say, that is emerging is that we are not that bullish on MDA5 report, and we really need to be bullish. Is that right?
Yeah.
What is your take, Steve?
Yes, absolutely.
Yeah. I think, as I said, once the MDA5 came back positive, that changes the whole ball game in terms of, treatment, being aggressive, monitoring the patient. But what's interesting to me is this recurrent pneumomediastinum,
Yeah.
and that's just very difficult to think how to manage that in terms of trying to prevent recurrence. I don't see any obvious blebs or cysts, but there probably is one or two there that I'm not fully appreciating because of the acute presentation. But even then, there's nothing you can do in this patient. You're not going to go into the chest and do anything. The patient, as I mentioned, is autopleurodesed already. Even here, I'm not sure this patient would be the best transplant candidate. She's 62. She's got active myositis. Her HbA1c is very high, so probably not well-controlled diabetes. So this is a really tough situation, which is very unfortunate in all these MDA5 patients.
Thank you, Steve. I think it's really very tough call. You said that we understand lung transplant is not such a big option in India. Not easy to, afford as well as to get it, and there's a long waiting list. But I'll ask you, Khushbu, that is there a worsening of fibrosis now in the CT scan, or you feel that in fact
So I lost your voice towards the end.
Khushbu, are the lung changes worse or better or same as previous episode of pneumomediastinum?
Sir, more or less the lung fibrosis has remained kind of stable between the last pneumomediastinum CT scan and the current CT scan. But one thing that comes to my mind is that the cause of this recurrent pneumothorax is possibly the speed at which the background fibrosis is progressing, which is not leaving enough time for the lungs to recoil back. And especially in a patient who has a background muscle disease, the chest wall is also not recoiling at the same speed. And because of this kind of a tension at the two ends, the pneumomediastinum is possibly developing.
So we'll move on to the next slide, Rahul, and I'll in the meantime ask Steve that what would be your take option also how to treat it. Actually, they're showing what we did. We gave another methylprednisolone 1 gram and IVIG and continued with rituximab, and MMF dose was increased finally to 3 grams per day for this patient, basically. So what would you recommend beside transplant, of course, which is not an
Yeah.
option?
Yeah, not on the table. This is really tough. I see the nintedanib was added. It's hard to imagine that any medical therapy now is going to reduce the risk of recurrent pneumomediastinum. I think the one thing, thankfully, is that the lungs aren't dropping, because I think if she dropped one of her lungs, that could be the cause of her demise. But I really can't think of any other management options to prevent recurrence of the pneumomediastinum. It's gratifying that the fibrosis hasn't progressed, but I still agree with, but it's been a short time frame. I still agree with adding the nintedanib for what it's worth to prevent further progression. I think what's curious to me is how symptomatic she is during the intervening time period between the pneumomediastinums, if she's pretty well compensated or not. But at some point, discussion about palliative care and end of life might become appropriate, unfortunately, in this patient, even though she's only 62, which for me is still quite young.
True, absolutely. She herself considers herself to be very, very young. She's a teacher and she's living a quite a normal life. And she was actually quite healthy between the episodes, whatever all happened. So that was more of a reason for us to be like to see how to prevent the third one which is coming, which hasn't happened so far. But we do not know because we are just 1.5 months after the last episode, nearly 2 months. So Smriti, I will ask
Sorry,
you.
one thing I would add, which we've done in some of these patients, is if you know where the where this pneumomediastinum is coming from, as I mentioned, you're not going to go in and do anything to those lungs, but sometimes we've used endobronchial valves if you can localize where the leak is coming from. But I think in a case like this where there's not an active leak, that's going to be extremely difficult. There's not like one area where there's a cyst where you're suspicious where you can go in and put a valve. But in other cases, that could be a consideration.
So I think Steve is trying to tell us that if there is an area which you think is leaking again and again, you can put a valve there to stop that altogether. In this actually we never thought about it, very frankly telling you, and also we were not sure that where the leak is coming from. The CT scans never gave any clue to us. And I can go
Right.
back to you also to asking that is there anything to tell us that whether the left lung is leaky or the right lung is leaky? But it is going to be a very tough call basically. But I will ask you, Smriti, that we continued with rituximab. Would you have recommended cyclophosphamide at this point of time for this patient? Because we realized that fibrosis has not increased, the inflammatory component doesn't seem to increase in the CT scan. So we continued with rituximab. But as a rheumatologist, if a patient, somebody on rituximab comes back again like this with MDA5, would you say change to cyclophosphamide now?
For this patient, I don't think so, because you look at the various side effects of cyclophosphamide, and then sometimes you have to stop it, and there are many issues. She's already not very immune competent. She has a high HbA1c. She's 62 years old. And looking at these parameters, I would rather go for safer options. That would be much better. And
So I'll ask you, Smriti, on that case. Now she's discharged. She's
yeah.
on 3 grams of mycophenolate per day. She's on steroids, and she's on rituximab as a maintenance therapy, which is going on. Would you still like to add an inhibitor or a calcineurin inhibitor in this patient?
Yeah, I think a calcineurin inhibitor will help her. I think
So,
so. And secondly, I just
will
wanted to
still
ask
consider.
whether she's putting on weight.
Yeah, she has put on weight actually because of steroids, but her diabetes has gone totally out of control at this point of time.
Yeah, because MDA5, when it was not like uh, a decade back, we were talking about this amyopathic myositis. And these were the patients who were at, we would screen them very vigorously for malignancy, underlying malignancy.
Actually, initially, Shruti thought it is amyotrophic because there is
Yeah,
nothing wrong with the muscle, and we
yeah,
did a PET scan thinking that okay, the PET scan was done incidentally first rather
yes,
than later on, but we were happy that we have screened that
nothing comes.
malignancy
Yeah,
anyways. But
yeah,
then the skin and everything came up. It's a dermatomyositis in this patient, which told us that it is not amyopathic or maybe a overlap. We do
yeah,
not know about that. But yes, this is always a question that when you are under or when you are over as far as immunosuppression is concerned, it's a very
yeah.
difficult question. And MDA5 poses all these kind of questions. So I will leave this case with only one question to Steve. What kind of vaccinations should be given to these patients? That's a uniform question asked all over, that how to vaccinate them, because we have Shingrix, which is inactivated zoster vaccine. We have a Prevnar 13 and we have a Pneumovax 23. And of course, influenza we give to every patient. So question is, which ones to give, when to give?
I would give all available vaccinations, Prevnar, flu, COVID. I don't know if you have RSV, I would give all of them, because in someone like this, and especially because she's well compensated between these episodes, probably a big risk, especially if you added a calcineurin, is infections. So I would give them now. I wouldn't pull her off her immunosuppression because of concerns about not mounting an immune response. But as you consider adding a calcineurin inhibitor, maybe do the vaccinations beforehand. But it goes back to the point of your question about Cytoxan. I think a risk to this patient is, predisposing her to infection. So I agree. I don't think the Cytoxan is going to save the day. But I agree. I think, adding the CNI, adding the antifibrotic, and then, do vaccinations and any other prophylaxis. I see she's on Bactrim already, I think are perfectly appropriate.